Yeah, we are live now. Over to you.
Okay, yeah, thank you. Yeah, Sridhar sir, Anand sir, Anu sir, shall I start, sir?
Yes.
Yes.
Yeah. Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I'm Balaji, a great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on beta-gluten, titled Views on Beta-gluten. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us to navigate through the entire meeting, we have with us today Dr. Sridhar sir, who will be our moderator for today's panel discussion. Welcome, sir.
Good afternoon. Good evening.
Good evening, sir.
Yeah. Sridhar sir is a more faculty for all the doctors in Tamil Nadu. Let me take this opportunity to give a short introduction about our moderator, Dr. Sridhar sir. Dr. Sridhar sir is a senior consultant endocrinologist. He is practicing at Chennai. Doctor is the head of the Department of Endocrinology and Diabetes at Neon Hospital, Chennai. Doctor is practicing at Neon Hospital from 2008 onwards. Doctor was an ex-consultant endocrinologist and HOD at NMC Specialty Hospital, Abu Dhabi, UAE. Doctor also was an investigator for various clinical trials in diabetology and endocrinology. And Doctor was a recipient of many awards. One great award is Doctor has been awarded Best Doctor Award by Tamil Nadu MGR Medical University in the year 2012. With this short introduction, I once again welcome Sridhar sir. Welcome, sir.
Thank you, Dr. Balaji. Thank you for that kind introduction. Good evening to all. At the outset, I'd like to thank Alchem for this novel meeting, and I'm happy to be the moderator. We have with us four eminent doctors. The fifth one, unfortunately, could not make it. The first one is none other than Dr. Anand Moses, most well-known diabetologist, former professor of diabetology, Madras Medical College, and head of the department, and eminent diabetologist. The second one is Dr. Anand Kumar, who's consultant physician from Chennai. The third person is Dr. A. Srivatsa, a diabetologist from Chennai. And finally, Dr. R.B. Sudhakar Singh, also diabetologist from Chennai. And unfortunately, Dr. Chellamariappan could not make it. So today the topic is, as told earlier by Mr. Balaji, it's about vildagliptin. All of us know about vildagliptin. All of us have extensive experience with vildagliptin because it's been more than a decade since it's introduced in the Indian market. And I must say, it has made a solid name for itself. It is a 50 milligram tablet, which usually is given twice a day, and is one of the most popular drugs in diabetology practice. And recently, that is about 2 years back, in the European Association of Study of Diabetes meeting, a very important trial has been published, and that is known as the VERIFY trial, which for the first time established the importance of early combination therapy and how effective it is to prevent complications and help the patient with submaximal doses of the individual drugs, where vildagliptin and metformin were used to achieve the results of the target HbA1c, and also having less patients from primary and secondary treatment failure. So the next few minutes, we will be discussing the verified trial. And I think I'll set the ball rolling with Professor Anand Moses. And sir, please elucidate your experiences with the same.
Thank you, Dr. Sridhar. I think after a long time, we had a major study just published a couple of years back. That is a verified study. All along, the criticism was there was no long-term study with vildagliptin, and there is no CVOT with vildagliptin and other things. That is why probably this drug is not still available in the US market. The FDA approval is not there because this is one gliptin which does not have a robust CVOT study. But there are a number of other studies to prove its efficacy as well as CV safety. One of the nice study, one of the very bold study I would say is a verified study, where if you see the type of patients who are taken with a HbA1c of 6.5 and 7.5. At the time of diagnosis, with the 6.5 and 7.5, and I think it is within 2 years of diagnosis of diabetes. And to include a group with the 6.5 and 7.5 requires a lot of courage. There were 2 arms in the study. It was a 5-year study, and there were 2 arms in the study. One arm was on metformin, another arm was on a combination of vildagliptin plus metformin. And when there is metformin failure, vildagliptin was added to the study and the patients were followed up. I think we'll take up further. This is the basis of the study. There were 2 arms right from the beginning. One is a combination arm of metformin and vildagliptin, either 50 by 500 or 50 by 1000. Another arm contained metformin alone. And this was the, and it's a follow-up for 5 years study. I will not go into the results. I think Sridhar can take forward from here step by step so that we can have some discussion.
Yeah. Yes. Thank you, sir. Now it's Dr. 1 minute. We'll ask the next question to Dr. Sudhakar Singh. Dr. Sudhakar Singh, what Dr. Anand Moses had said, what do you think is the rationale for combination therapy at this early stage of HbA1c 6.5 to 7.5? What are your views on this?
Good evening, one and all. We've been used to starting a monotherapy. I mean, the most common legend for monotherapy is metformin. But there are some unique features for our Asian population when compared to Caucasian population that in India, the average, duration in which we diagnose diabetes itself is almost 10 years later than our counterparts in the Western world. So if you look at that data, we are diagnosing patients at a very, very late stage. So when we start, when we have a patient population who have been diagnosed very late as newly diagnosed diabetes, I think it, as Professor Anand Moses said, it is imperative that not to waste time and to start a very stringent, a protocol of management with early combination, which, as Sir had already said, by verified trial has clearly shown that the primary failure is much delayed when you start early combination in this group of people.
Okay, thank you. Now is the turn of Dr. Anand Kumar. Dr. Anand Kumar.
Yes, sir.
I think the AACE and some of the ADA data are saying that if the A1C is 7.5% above the 1.5% above the target, then you can straight away start combination therapy. Why do you think they started earlier in this case?
You all know that during all this PKPD study included newly diagnosed patient. They found out in the initial stages itself around within 3 years, 50% failure happens with the monotherapy. and 75% with 9-year study. So they found out the Verify has given a very good composition that if you start early with the combination therapy, you can reduce the delay in secondary failures and as well as primary failures. And as well also with the glycemic durability, it has clearly shown that compared with current treatment of stepwise monotherapy going on to combination therapy, we can it is delaying the progressive failures. So we can straight away start with combination therapy. This is the Verify trial is given.
Okay, thank you. Now, finally, Dr. Srivatsa, your views on the same.
So when we combine with metformin, the vildagliptin, the efficacy is better and the glycemic control achieved is better, and it has favorable effects on the beta cell, and thereby it has been beneficial in combining both metformin with vildagliptin as the first line or a second line early therapy. It's good.
As
Yes,
Sridhar said, contrary to all the guidelines, if you look most of the guidelines, they will say when the HbA1c is more than 1.5 above the target, think of a combination. Contrary to that, this study was started. One of the reason was if you look at the pathophysiology of type 2 diabetes, it is never insulin resistance alone, never insulin secretory defect alone. It's a combination of both. So they thought, why don't we attack both the pathophysiology of type 2 diabetes right from the beginning, so that people preserve their beta cells much more, and failure to drug is less. That is what they initial thinking of, and that is what I think they have achieved also.
so in the light of this particular study, what do you think is the future of monotherapy? Will one think of when would you only think of monotherapy with either with metformin or with vildagliptin alone?
From personally, even the fasting blood sugars are alone. It is very difficult to say after the Verify study that you will start only on metformin or with thing. But still, I would say when the blood sugars are not, HbA1c is less than 7, and I would still like to start on metformin alone rather than add one more drug, which would probably be a added cost to the patient, and probably monitor the patient more closely. And then I would think of adding a vildagliptin. If there is a progression within 3 to 6 months, I may add a second drug. But still, my preference at this range of HbA1c with metformin monotherapy, we can go up to 2 grams. I don't know, Sridhar, your view on that?
No, I am not a great fan of metformin monotherapy. So even before the Verify study, I used to at least add. They used to give us at that time, although it is off, not the off guidelines, but I still used to give a low dose combination. Mine was not based on any guideline. My idea is mostly the postprandial sugar is very higher, and the fasting is near normal. And I used to feel that metformin has a very modest effect on postprandial sugar. So it doesn't make rational sense to just give metformin alone in such cases. There are some rare cases of Dawn phenomenon and other cases where fasting alone is high. And that situation, a bedtime metformin is maybe a good solution to suppress the early morning
hepatic glucose production.
Yes, glucose production, and also the early morning hyperglycemia. Otherwise, in my experience, I think even a single dose combination, a single dose, that is one dose of a vildagliptin metformin combination, will do much better than giving metformin twice a day to these patients. This is my personal experience. I wish to hear other esteemed panelists what their views.
As you said, it is clear, sir, that with the initial stages itself, we just give the combination therapy, we can bring down this glycemic control at a very good level with intensification. I think it gives a good, better to start with combination therapy in spite of all the guidelines. As per Indian study, Indian patients, we are all mostly 90% carbohydrate full day meal. So to control postprandial, we need combination therapy that works better, sir. This is my views.
Dr. Sudhakar Singh, Dr. Srivatsa, any views on the same?
Combination therapy reduces the glycemic variability. Thereby, better control is achieved with combination therapy. Definitely. When to start it is definitely monitor the new patient frequently. In about 2 to 3 weeks, we'll know where he stands and how he's able to achieve his sugar control. Once you monitor him well, we can always add in drugs if the sugars are not better controlled.
Sure.
In my opinion, probably when we look at a diabetic, we should also look at the other comorbidities which he has, like very morbidly obese patient who is also a hypertensive or coronary artery disease to start with, because as I told, this late detection of newly detected diabetes. So these subset of people, instead of starting monotherapy, an aggressive combination would definitely suffice. Plus metformin to the highest dose, as Professor Anand Moses has said, 2 grams or so. Some of our Indians don't tolerate it also. So a moderate dose of metformin with a combination of a DPP-4 inhibitor in a subset of population whom we think that an aggressive control is warranted at the earliest. Plus, probably in a long duration, you feel that this patient might go in for failure. So starting a combination for a very subset of people early is definitely worthwhile considering, sir.
Thank you. I think I'll move on to the second question. All of us are now agreed that combination therapy is an effective option. It could be sometimes a primary option in treating type 2 diabetes. So next question would be what combination to choose. Of course, vildagliptin, in my experience, can be combined with any other drug, literally. But of course, there are some logical choices. And in my opinion, vildagliptin metformin is a very logical choice. There are many situations where we combine vildagliptin with insulin, and we find that the insulin dosage is reduced and patient gets much more effective control. And also sometimes a SU metformin combination, a vildagliptin would be another logical choice. And of course, now vildagliptin in the post-patent era is being combined with SGLT2 inhibitors in a fixed dose combination also. And that is a very cheap and effective combination in that you get 2 drugs for the price of 1, 2 very good drugs at the price of 1, doing a marvelous control of sugar in addition to metformin. So to discuss their views on the various combinations, we'll start with Dr. Anand Moses. Sir, you please go ahead.
In a early stage of diabetes, particularly when the HbA1c is on the lower side, we do not want hypoglycemia. That is an important thing. So, and when we look at a combination for metformin, there are 2 choices I would think. Of course, we have all used glimepiride and glycoside in patients with very high sugars. I'm telling patients with around HbA1c of 7.5 rate. And as Dr. Sridhar said, when postprandial is a big problem, there are 2 things I would think of combination with the metformin. One is an AGI. In the Indian situation, either acarbose or what is the other drug? Acarbose. Voglibose. Acarbose or voglibose as a metformin combination would be was always the ideal drug for me. because vildagliptin was always, most of the gliptins were expensive, and telnigliptin was not a very efficient gliptin. I think with the price reduction, which Dr. Sridhar mentioned about the generic form of vildagliptin, I think the whole scenario has changed now. We have a useful combination which addresses both insulin secretory defect in a glucose dependent manner, as well as the fasting blood sugar with metformin. So the combination now has shifted from an AGI metformin to vildagliptin metformin. I think this has come to stay for a long time. This will be a, and with the added impact from the verified trial, I think it is worthwhile, a good ideal combination.
Dr. Anand Mohan.
Yeah, you all know that diabetes is a progressive disease. So to intensify therapy, the early control itself gives wonders. As yet study has clearly given that if you start with the metformin with vildagliptin, compared to any other combination, it works better, even with to reducing the secondary failures and primary failures. Even if you can add with the vildagliptin, metformin with sulfonylurea, it reduces the hypoglycemic events also and reduced glimepiride usages also. And insulin also we can use it. So with as Anand Moses have said, with the Oglibos and Acarbose, stuff that we can use very well this. With SGLT2 inhibitors, it works with a good control over HbA1c as well as good benefit of heart failure benefits with dapagliflozin. I think it works very nicely, sir. This is my opinion.
Dr. Sudhakar Singh.
Metformin monotherapy is probably what is the regular practice. But if asked for a treatment-naive patient, I would go for a metformin plus DPP-4 inhibitor like vildagliptin as an initial combination of choice. But for patients who are already on OHAs, like multiple drugs like sulfonylureas, acarbose, metformin. So these multiple drugs, if they are going in for a treatment failure, I won't be comfortable in continuing sulfonylureas and then adding on a new drug. My preference would be to pull off the sulfonylureas and probably add a DPP-4 with SGLT2 inhibitor also. As people all know that both SGLT2 inhibitors and DPP-4 inhibitors has some kind of a synergetic action, which probably can complement one other action. So that combination, I would prefer, substituting sulfonylureas for this combination. Otherwise, metformin, vildagliptin, my initial choice. For people who are already on multiple drugs, pull off sulfonylureas and probably add both DPP-4 and an SGLT2 for a better control of sugars.
Thank you. Dr. Srivatsa, please.
So the ADA guideline says that to add in the second drug, if you'll have to check out if they have heart failure or a cardiac event or predisposition to cardiac or renal component is involved. Based on that, we have to decide metformin with DPP-4 and with SGLT2 or that way. It is only when the cost is a factor that DPP-4 with metformin and sulfonylurea can be decided, because economic wise, it is with the generic drugs, these are economical. So based on the involvement of the heart failure and the renal impairment, we can decide on what to do. But across the board, we can use metformin, DPP-4 as a combination.
Okay. Okay, thank you. Now, another point which I wish to raise. Normally, in the combinations, especially an SU metformin combination, in my practice, although vildagliptin is termed as a twice daily molecule, many an occasion, 50 milligram once a day is doing the trick. And earlier, we used to do this in the light of price consideration, that one tablet will be just used to be a 20 rupees, 20 like that. And so that won't be very expensive. And still, it used to do the trick. Of course, now with the patent off, now it's the cost is less of a factor. But what I'm intrigued is this new, many companies have come out with 100 milligrams OD of metformin. Metformin used to be 50 milligram BD, but now they have come out with the Vildagliptin 100 milligrams OD. So what do you think will be the impact of 50 versus 100 in this situation?
I think someone else can start. I will answer.
So we'll start in the reverse order. We'll start with Dr. Srivatsa.
Sir, it helps us in dosage convenience. We'll have to wait and see how it is effective in management of diabetes, because we have used the sitagliptin as a single dose. My experiences, there are about 10 to 15% failures in all DB4 usage, both in type 2 doses or single dose. But still, we'll have to try it out and find out how it comes out. I have no great experiences single dose Vildagliptin of 100 milligrams yet. It's slowly starting to increase the prescriptions. But with the experience with other Vildagliptin as a single dose, sitagliptin or linagliptin, it has been effective also. So must be effective.
Dr. Sudhakar?
Single dose preparation of Vildagliptin, I'm not sure where exactly they can fit in our clinical practice. Because when we use metformin as sustained release, we conventionally use it twice a day. So even in conventional Vildagliptin, like 50 milligram BD will go well with this metformin sustained release, which are being given twice a day. The only area which probably I think would best suit, Vildagliptin single day dosage would be people who are solely on insulin and wants only a DPP-4 inhibitor as an add-on for insulin. So once a day of this drug, plus probably twice a day of premix or a basal dose, probably will give some convenience to the patient. But for initial patients who are treatment-naive patients who are going to be on metformin, ideally we are going to give it twice a day. So I think the conventional dose of 50 BD should probably be convenient for the patient when it is taken or combined along with metformin. That is my take on this.
Dr. Anand Mohan?
You all know that we have to consider the comorbid conditions also. The patient is with CKD or some other issues, we cannot give 100 milligram. So we have to reduce the dose. Second, to reduce the polypharmacy pill, we can give morning Vildagliptin and the evening 1000 milligram of metformin to cater both fasting and PP in the initial stages. But as other panelists said, we have to wait and see what is the outcome of this.
Yes, I think all of us have very little experience with the once a day. It is just hardly a few weeks since it has come. One situation where it may be useful is where probably we cannot use metformin. Probably a patient has metformin intolerance. Probably you could use once a day. And Sridhar, if you remember about when Vildagliptin was introduced almost 20 years back, initially it was introduced as 100 milligram twice or once a day. And they had found this liver enzymes going up. That is why they split it into 50-50. I think the present 100 milligrams, they should have sufficient studies to show that it is safe. Because one of the side effects of Vildagliptin is on the liver. Liver enzymes rise in some people. And it's also contraindicated in patients with liver disease. And I don't know how this once a day 100, any studies done on liver problem, because the original Vildagliptin was split into 50 and 50 because of the liver enzyme rise. Probably Sridhar will be able to throw more light on this.
Of course, I'm fully aware that it's contraindicated in hepatic insufficiency. But personally, I'm not right now. I don't think I can throw light regarding that studies. But your point is well taken. I think we need more experience before we go wholeheartedly into this 100 milligrams OD. But this is the current trend in the last last 2 weeks, 3 weeks in the practices. Everybody is coming out with the same 100 mg. So that's why I raised this point for to get the expertise of others. Okay, let's next move to another area. Of course, now the CKD is an important part of parcel of diabetes. Diabetes being the most important cause of diabetic nephropathy, and diabetic nephropathy contributing most important cause of CKD. And of course, we have metformin. Metformin now is not such a bad guy. The nephrologists seem to accept it more often, and below 60 ml per minute, they say use it in half dose, and below 30 ml per minute, then it's contraindicated. SGLT2 inhibitors are now the new saviors for the nephrologists. And now, as the DAPA CKD trial showed, up to 25 ml per minute GFR, the dapagliflozin can be used. Because although the glycemic efficacy is reduced below 60 ml, it seems to be improving, and the kidney condition, reducing the chance of dialysis, end-stage renal disease, etc. So the DAPA CKD was threw light on that. And so the nephrologists and cardiologists seem to be more enthusiastic than us in using these drugs. Now, gliptins were always considered the safest choice in CKD. And linagliptin, of course, and teneligliptin to some extent do not require dose change. Vildagliptin is considered safe, but less than 60 ml, it's converted to once daily. So usage after that, even I think it's used even in dialysis stage and ESRD stages also. So I want to again ask all the panelists their views on vildagliptin in CKD. I'll start with Dr. Sudhakar Singh.
CKD probably is a very challenging situation when we have diabetes on one side and CKD on the other side. One, we need to prevent or retard the progression of CKD. That we can achieve only with good BP control and good sugar control. One, we need to aim at that. And we need to probably use the most safest drug for CKD patients. In respect to not causing more damage to the kidney. Third one, the drug which shows the least chance for hypoglycemia. So when we take all these parameters, the first thing of our choice would be a DPP-4 inhibitor, obviously, because it has very low incidence of hypoglycemia, very safe in CKD patients with dose adjustment, as Sarah has already said. With appropriate dosing, it is very safe with less hypoglycemia, and with effective sugar control, it can retard CKD progression. And we all know that diabetes itself is a risk factor for macrovascular disease. And CKD, when it combines with diabetes, has a very, very high chance of people developing macrovascular complications. So having a sugar under good control with least chance of hypoglycemia, I think my choice with this regard, I would favor a DPP-4 next only to insulin.
Dr. Anand Mohan.
Yeah, as Sudhakar sir said, you have to consider CKD and diabetes, hypoglycemia with insulin. So when to prevent hypoglycemia, it is better to go with the DPP-4 inhibitor with a small dose of insulin if required. As the Sridhar sir suggested, metformin contraindication less than 45 ml. And SGLT2 inhibitors can be used up to 25 ml eGFR. Then considering all these things, DPP4 is the safest drug. Again, to come to vildagliptin, we have to reduce the dose, whereas with linagliptin and teneligliptin, dose reduction is not required. With the Sita and the Vilda, we need to reduce the dose. Considering all these factors, we can go for insulin. The next choice would be DP4 inhibitor to reduce the hypoglycemic events in the CKD patients. It is unpredictable hypoglycemia can happen in CKD. That is my view.
Dr. Srivatsa?
Sir, my experience with Vilda, I don't use vildagliptin with CKD. Probably early nephropathy, we can use it with half the dose. But when there is alternative DPP4 which can be safely used in CKD patients, we can always shift to other DPP4 inhibitors. Then use vildagliptin. We should use half the dose. That is what is the recommendation.
Why do you think so? I think just all that is required is a reduction of dosage. Do you think? I think 50 milligram OD vildagliptin will be almost as safe as linagliptin.
Yes, yes. I don't say no. But it's just that now it is convenient, but it is always. I have used more of linagliptin in the CKD patients compared to vildagliptin, because there is proven safety records in that.
Dr. Anand Moses?
Yes, nothing more to add. Just to reiterate what Srivatsha said, our experience has always been more with linagliptin and renal failure. The company itself burnt their fingers, they thought linagliptin, renal failure, people thought it should be used only in renal failure. Now they are not promoting it as a drug useful in renal failure. But we have all been using. I've used very little, but as Sridhar said, all DPP4 inhibitors are safe in renal failure. Only the dose has to be adjusted. If your patient is already on vildagliptin twice a day, it makes sense to make it once a day. Probably starting a new drug, you could think of a linagliptin or a SGLT2.
I think cost also here probably will play a role, sir.
Yes.
And now with the CKD patients who had no other choice except for linagliptin, now has a alternative cheaper drug which can be given once a day.
In fact, the teneligliptin could be used also, but we never used.
So looking at the cost, probably we can, in certain situations, can favor vildagliptin.
Yes, you're right.
That's, I think, a very good point you made, doctor, because a CKD patient is financially very challenged. He has to pay through his nose for everything, for dialysis, for if he's going a transplant, everything. So anyway, we can reduce his financial burden without causing damage to his health is most welcome. So your point is extremely valid. So we'll now move to the next topic, the elderly. The elderly, I think they represent a significant challenge in treatment of type 2 diabetes. They are different from others in that we are a little more relaxed on their HbA1c, where we are accepting up to 7.5 to 8% HbA1c. And we are not desperately trying to control the sugar, whereas we are more concerned about their hypoglycemia, whether they will be suffering from hypoglycemia, which will be a very much more bigger problem for them. In this situation, I think drugs like SGLT2 inhibitors, which are otherwise so well talked about, are a very poor choice because of problems of osmotic diuresis and dehydration, etc. Again, metformin is a safe drug, but many people are renally compromised and may not be in a position to accept metformin. In this light, DPP4 inhibitors probably are the drugs of choice in the elderly. And in my experience with vildagliptin and the elderly has been uniformly good. And sometimes I combine it even with metformin once a day and find it to be a very safe option for my elderly patients. So I would like to know the views of our esteemed panelists on the same. We'll start with Dr. Anand Moses this time.
Yes, as you rightly said, elderly people are a different population to treat. There are two types of diabetes. One is diabetes of 25, 30 years becoming elderly. Second is people getting diabetes at an old age. I think the two are different. One is people with long duration have comorbidities. And the newly detected diabetes above the age of 70, as Sridhar said, we will not give so much importance to tight glycemic control. And I have a lot of experience with using metformin in the vildagliptin in the elderly. And as he rightly said, many newly detected diabetes, I used the vildagliptin even those days once a day, 50 milligrams. Because many of them I find have this metformin intolerance, which they do not reveal unless you ask. And vildagliptin once a day in many of the elderly with mild to moderate newly detected hyperglycemia in the elderly, I think it's an excellent choice. For others, we have to look into the comorbidities.
Dr. Srivatsa?
Yes, again, Dr. Anand Moses said, people becoming old with diabetes is a different patient, and people detected with diabetes at now old age are different. So DPP4 is definitely a good molecules to initiate after metformin or as a first line of choice, because it prevents hypoglycemia. You don't cause hypoglycemia in them. Sugars control are better in using vildagliptin or a DPP4 inhibitor with in an elderly patient. It is safe, so it is a good molecules to start off.
Dr. Sudhakar Singh?
Frankly, I don't have very extensive experience on very elderly people. But one point probably of consideration is as people grow old, like 65, 70 plus, it is more of postprandial sugars which probably will create a lot of issues rather than fasting. So they do not have insulin resistance at that age. So instead of targeting insulin resistance, probably postprandial could be a better way to handle diabetes in those populations. In that situation, I think as Moses sir said, withholding even metformin and keeping them only on DPP4 inhibitor for good glycemic control. Good in the sense an acceptable glycemic control like 7.58 can be easily achieved with a monotherapy of even DPP4 if they are newly diagnosed at the later age. For people who are already having diabetes, who grow old and who are already on multiple medication, we need to probably trim down medication which causes more hypoglycemic chances. And when we trim down, I think the last one probably which we will trim down is a DPP4. So that will still stick on to the patient as he grows older. So DPP4 has a place in either population of this elderly.
Anand Mohan?
The pooled analysis of all the studies which are done with the elderly population, it is clearly shown that DPP4 inhibitor is quite glycemic variability, and as well as it controls the postprandial sugars nicely, and reducing the comorbidities, as well as the reducing the cost after this patency is over. So considering all these factors, we can straight away go with to reduce the comorbidities and history of fall and the CVD issues with hypoglycemia. I think vildagliptin scores over.
Thank you. So I think we are coming to the last and final question in our discussion today. And I think probably now it's 1 year and a little more than a year since vildagliptin went off patent. And literally a plethora of many brands have come. And the physician seems to be spoiled for choice. And so we are now also in it going off patent. It's now possible to have combination. In India, fixed dose combinations have come very early, much before the Western countries adopted such practices. So now more and more people, we were using teneligliptin earlier. because it was not having many studies just because of the price. But now the more established molecule, which was hitherto unaffordable for most of the population, now becomes affordable. I think all the practitioners will take advantage of that and use this much, you'll have a manifold increase. And many combinations are possible. So about this, their views on this vildagliptin usage in the post-patent era, I'll start in the reverse order, start with Dr. Srivatsa.
Yes, please. Definitely, my usage has increased after the post-patent. One, because it's a more tested and tried molecule when compared to teneligliptin. So my usage has definitely increased over after the patency has gone, and it has been useful to the patients and affordable to the patients.
Dr. Sudhakar Singh.
Sir, as you rightly said, probably this removal of this patency is going to eat away the market of teneligliptin, because teneligliptin was enjoying a good market share, having the price advantage and being a very, safe OHS with respect to its class, DPP-4. Now that the pioneer has come with the lower rate, vildagliptin, and I think the market share of teneligliptin will definitely be eroded by this vildagliptin. And physicians and diabetologists are seeing more and more opportunity to add vildagliptin in their day-to-day practice, since that cost, inhibition factor is completely removed.
Dr. Anand Mohan.
It does not only, vildagliptin not only reduces the glycemic burden as well as economic burden also. When considering off patency, now the price is reduced from 40 rupees to 10 rupees per annum. They are saving a lot by using this vildagliptin molecule for the patients, as well as benefits to all the comorbidities which other drugs are having it. So it is very well be useful, sir. Now I have used very frequently for all the patients.
Professor Anand Moses.
Yes, I think this is the last question, isn't it? We are finished
Yes.
with this. I have another complication with vildagliptin. All of you told about the benefits. My biggest complication is too many companies have, and all are my friends, whom to satisfy. Every company has got vildagliptin. So every company says, give a share to me, give a share to me. But our share of patients have not increased that much, but still
Patients are decreasing.
we have to share, give a share. Problem now rather than the cost, the reduction of the cost is put into this complication. Thank you, Sridhar.
Just another interesting question, interest to me rather. I accept that linagliptin has a different place, special place, so it's got its role. Now, with the post-patent era, where do you see the role of sitagliptin hereafter?
Next year, sitagliptin is going to go off patent. Mid of next year. It's only a few months away. So the same, we'll have one more gliptin in the affordable range. We wait for a few months.
Sure. So definitely, we should all agree it's an exciting time to practice diabetes mellitus.
Yes.
In the the last millennium, we had only 3 drugs with us, and they were vouching for glycoside and glimepiride as latest drugs. Today, 20 years later, there's literally a plethora of drugs bombarding us, and more are on the anvil. I think all of them will be introduced after the lockdown is ended. So definitely, I think it's an exciting time. And I also found the last 1 hour, 45 minutes very exciting. And we had some very interesting views from the esteemed panelists who gave us benefits of their extensive experience. So, but all good things should come to an end. And now with that, I thank all of you for their lucid explanations. And now it's back to Balaji Kumar.
Sir, thank you. In the final marks, I'll just take one I'd like to share the screen by presenting one slide on latest development of our vildagliptin. So allow me to present the slide, sir.
Yes, yes.
Yes, sir. Slide is visible, sir?
Yes, yes, visible.
Yes.
Sir, as all the panelists and moderator are highlighting about this one-stage formulation, so Gluvildamviews had brought, we are the second company to bring OD formulation in Indian market. We are, Gluvildamviews is manufactured with matrix technology, which ensures glucose control, continuous glucose control over 24 hours. So here we compared, once the patent was over in December 2019, so like we started formulating this OD. We done a 3 months trial wherein we compared with parent company 50 mg BD dosage and we are compared with Gluvildamviews OD. DPP for innovation is almost similar, sir, which is matching up with international brand, which clearly says like the Gluvildamviews OD is efficacy. You can expect a similar clinical benefit just like parent company BD dosage, sir. And also we have done the bioequivalence study wherein our Gluvildamviews is bioequivalent to innovator brand 50 mg BD dosage, sir. So this is the latest development of Gluvildamviews OD, and Gluvildamviews OD is also most economical vildagliptin once-daily formulation which is available in the market, which is priced at only 10 rupees to the patient, sir. And also our Gluvildamviews plain 50 mg is priced at 5 rupees, and M500 and M1000 which is sustained release formulation, which is priced at 6 rupees and 7 rupees only, sir. I request all the eminent doctors, panelists and delegates to take up this brand Gluvildamviews and Gluvildamviews OD in their clinical practice. So with this note, sir, I will, it's my pleasure to propose the vote of thanks. So, sir, it was a great evening which we had. So first, I'd like to take this opportunity to thank the moderator, our Sridhar sir, for accepting our invitation and moderating the panel discussion today. Thank you, sir. It was more of clinical experience which has been shared today. So all the panelists and moderator, you are completely giving a clinical perspective on this molecule, which will be more useful for all the delegates who have participated today. And I'm sure all the doctors, delegates who have participated, who are mostly expecting a clinical experience about any molecule which is being for the discussion. So that has been completely fulfilled today. I'm sure all the doctors will be appreciating the views which has been presented by all the panelists and moderator today. Thank you, sir. And I'd like to thank this opportunity, take this opportunity to thank all the panelists, Dr. Anand Moses, sir, Srivatsa, sir, Sudhakar Singh, sir, Anandakumar, sir, for giving us an opportunity and sharing the clinical experience on vildagliptin. Thank you, sir. So at this juncture, we'd like to salute all the doctors and paramedicals who have contributed immensely for keeping us all safe and healthy in these challenging times. So we at Alchem will continue to serve doctors and patients by making our products available, especially Gluvildamviews OD, Jipuros and Welcome. Thank you, sir. Thanks once again.
Thank you.
This evening and good night.
Thank you. Good night, everyone.
Thank you, one and all. It was a pleasure staying with you.
Thank you, sir. Sudhakar Singh, sir. Thank you, sir.
Thank you.